This
webinar
conference
that
will
we're
now be
having.
recorded.
Thank you so much. So just for everyone's awareness, this is being recorded and we are currently recording this session. So just a few slides and then I will hand it over to Rick. Let me share my screen. Let me know when you can see.
We will.
Are you able to see?
No.
Okay.
But we're getting there. We know it works, so because we
Okay,
just tried it.
Yes, let me just give me a second.
Rachna is an organizer, but not a presenter. Should I make her a presenter?
Yes, you have to be a
Yes.
Yes, I thought she'd made herself a presenter before she started. Now you're a presenter.
Okay.
Now you can share your screen.
Okay, there we go. Okay. And share. Let's see. Let me see.
Share is right at the bottom there.
Yeah, no, I have it. I'm not sure why. Anyhow, maybe what I'll do is just read off. There's just a couple of slides.
Yeah, please do.
So again, welcome everyone. Just for everyone's awareness, the information and opinions that we are going to be discussing are not intended as recommendations by AnCan or any of our representatives. So you should definitely consult with your doctor for any treatments. And I want to also thank our sponsors, Johnson & Johnson, Blue Earth Diagnostics, Novartis, Telix, Myriad Genetics, as well as Bayer for supporting us and also the webinar. We're excited to get started with the webinar regarding MRI second opinions on prostate cancer, which is going to be led by Dr. Randall Jones. So with that, I want to hand it over to Rick.
Hello, I'm Rick Davis, and this wonderful idea 15 years ago, that we could do all this stuff on virtually and presentations and support groups, and here we are in 2025, and we've got 35 virtual events a month, 12 for prostate cancer, plus webinars, plus this, plus that, plus everything else. So I feel very blessed to help the people that we're helping. I'm not sure if Archana mentioned all the sponsors, but just to cover ourselves, I will. They are Novartis, Johnson & Johnson, Bayer, Myriad, Telix, Blue Earth, Foundation Medicine. Did I miss anybody? I hope not. I did. I'm sorry.
I think you got everybody. Yeah.
Thank you. Okay.
Yeah, I think I went a little too quick. Go ahead.
Just a couple of ground rules. First of all, please keep your microphones muted so we don't get any background noise. What we're going to do today is listen to a great presentation from Dr. Randall Jones, which is going to leave loads of time for questions, which we know our audience, our participants really enjoy. After that, we will go straight into a support group meeting for active surveillance, which is a weekly occurrence in the first 4 weeks of every month. So anybody who's here and wants to stay for the active surveillance support group, you're welcome to do it. We at AnCan, we separate education and support, because some people want the education and not the support, and vice versa. We'll be putting ways that you can sign up for reminders in the chat window. Chat windows in the on the right-hand side, the little two squares. You can put comments in there, you can put questions in there, but we'll be taking questions live right from you, and we'll give you instructions on that later. Which leads me right into welcoming our guest, Dr. Randy Jones, but for me, more especially, Commander Mike or Bing Crosby, who is a really valued member of our advisory board, has guided me personally. He's one of the few people that really gets me, so I listen to what he has to say to me, and I need my minders, and I consider Bing to be one of my minders. He has an amazing history for all the way from being a Top Gun to being a veterans advocate and starting a fantastic organization which is currently in abeyance. And as well as all of that, he's a two-time, he lives with two different cancers. That's the way I would prefer to put it. He lives with two different cancers, so he's well up, and one of them is prostate. So with that, I'm turning it over to you to introduce Dr. Jones.
Yeah, thank you. And much more than a minder, I'm just a friend. We'll put it that way. So I'm Mike Crosby, call sign Bing. I did have Veterans Prostate Cancer Awareness for about 10 years. We're actually in the midst of merging it with a greater good we can announce now called Military Aviators Coalition for Health. And when the IRS gives us our the 501c3, it will then start to flourish. But President Trump just signed into law the ACES Act a couple of weeks ago, and we're actually working on another funding line for looking at causal factors for various aviator-related cancers, which are at a much higher incidence rate than the general population. So with that, though, I've taken a new job. I'm the Chief Commercial Officer at Bot Image. Bot Image is an AI company. It was founded by our speaker tonight, Dr. Randy Jones. Randy had a very successful career. He's an Air Force veteran as well. And he had a company called ScanMed, which actually, what was it? I think you've been in MRI for about, I won't even say the number of years, but a few decades is easier to say. ScanMed actually made components of MRIs and all the processing issues with MRIs. He has lived the MRI world for decades and understands it better than most. So in the last few years, Randy's also, I'll throw out there, as a survivor of prostate cancer as well. So he gets it. He gets all of this part of it. And it's been a pleasure to get to know him and to work with him. We have some very exciting news to put out there that we're going to talk about a product that is FDA approved. And it is in use in a number of hospitals and with a number of clinics. And we're working right now. My job is to scale this thing throughout the entire industry. Randy will also introduce how individual patients can actually access it on your own, and have you refer that back to your physicians if they don't even want to talk to you about a second opinion. I think it's silly, go get another doctor. But anyway, you can kind of take control of your own situation with your own MRI images. So with that, I'll introduce Randy and turn the floor over to you. And I think you can share your screen now.
All right. Well, thank you, Mike, and everyone. It's a real honor and a pleasure to be here. So, as he said, I'm also a prostate cancer survivor. So we have doctors, survivors, people on surveillance, ladies and gentlemen in the industry, all of you. I hope to impart some of my experiences and wisdom to the crowd and bring a little value to this organization. I do want to make a comment. I talk at academic meetings with radiologists and urologists frequently, so we always have to start off with the personal financial interest statement. Of course, I have a personal financial interest in this. I'm the president and CEO of Bot Image and founder. Also a co-founder for Precision Prostate Consulting, which I'll be talking about throughout the rest of the presentation. But that's not the profit motive is secondary, because I've had my own experiences that I want to relate to you. Before I even get into the slide presentation, I'll tell you this, that one of my first inventions, and I have about 25 United States patents, one of them was a wearable prostate antenna to significantly improve the image quality coming from that region of the body. And it's a challenging thing from a radio frequency electromagnetics engineer, which I am. I was demonstrating at the Mayo Clinic in Rochester, Minnesota about 10 years ago when I was a ripe young age of 59 years old, discovered my own cancer before anybody else had. That's how good it was. But the sad part of this was that was my first introduction then to become a patient, and their recommendation to a 59-year-old with not really a terribly aggressive cancer yet, I learned later after the pathology report, was to remove my prostate. Now, fortunately, I'd been educated on that enough to tell them where to exactly go stick their surgical tools, and said, we're going to have to go through a different route. And so really the purpose of this conversation tonight is the number one, and it's already been said by all three speakers before me, get a second opinion. Medical practice is not perfect. And one of the reasons that I've been successful in business is I find some of the bigger imperfections that are there and try to fill those with technology. So that's what we have. Without further ado, let me see if we can get this thing rolling. Okay, well, part of the other introduction is I've been fighting, and that's probably not the right word, but I'm going to say it. I've been fighting the system, if you will, of insurance, of slow adoption and everything else of new technology. And I actually am an author with Forbes books. I am the healthcare disruptor, and that's me standing there. That's standing there in Times Square in New York, introducing this book. It's still out there for available. I'm not selling books, but this book will tell you the rest of the story and tell you how that battle continues, because it needs to continue. And this is another chapter in that saga. So why are we here? You already know about this crisis. You're living it. You're in various stages of this. You may be in watch and wait or active surveillance. Whatever the case may be, I hope you get something out of this. But the reason I started this is not truly just financial. It's because of the slow adaptation and making this available faster to every one of you and everyone else in the United States and now Europe. And if the physicians, the radiology clinics, the insurance industry is not interested in making that change, then we brought this change directly to you via Precision Prostate Consulting. So who's involved besides me? I have key opinion leaders from both radiology and urology that are partners in this. And I have learned a great deal from both of those well-established physicians. One of them is well, they're all both board certified, but one of them is the radiology chairman at University of Texas Medical Branch in Houston, Texas, or Galveston, Texas. The other one has his own private practice in the South Miami area. So we all have this story to tell, and we all have this in common. So let's go see what we're going to do about it. Looks like we got some mics that are still on. If you would check those, please. Thank you. So we have we've got this product. It's called ProstatID. I'm going to go through the description of the problems we're solving, the introductions about PPC and bot image very quickly, and then just show you some of the benefits of making getting a second opinion, and then how you go about that. we already know about this problem, but here's some of the things you don't know, and this is why second opinion is very important. Blood test is good, and I'm sure that many of you on active surveillance are getting these routinely, and it's good medicine because it's inexpensive, it's very accessible, but the number in itself means nothing. What does mean something is if that changes over time rapidly. It's called PSA acceleration. If you have that, then it is more indicative that you may have a prostate cancer. Digital rectal exams are, well, I'm going to be very blunt tonight because this is amongst friends now. It's a joke. Less than 50% of the cancers are detected, and almost none of them in the anterior or far away from your rectum where the finger is. So I can tell you everything I say tonight is backed up by the clinical literature from both radiology and urology. Random biopsies are expensive. They cause a lot of pain and bleeding. Please, people, check your microphones. Check your microphones, please. Okay. So random biopsies, they're kind of a last resort for doctors to find a hidden cancer. Well, there's other things that one can do. And that is MRI. So now we've got it worse. Anybody know what to do about that?
What?
Okay.
Already did it.
Не соединяется с нами почему-то. Хотя пишут, что connected.
All right. Please keep your microphones muted. So here we have the computer-aided diagnostic system for, and Bot Image is the mother company. PPC, or Precision Prostate Consulting, was started again to bring this directly to you. Bot Image is a medical device company that has the licensing, the FDA clearances, and this program was adopted from the National Institutes of Health back in 2019 and made into a commercial product. And it is being sold and licensed, if you will, to hospitals and medical facilities throughout the world. So the way it works is simple. You have to get an MRI because what it does is it's learned from 2,000 MRI patients, 6,000 biopsy points. It knows how to detect a cancer and classify that, or a lesion, I should say, and classify that lesion as cancerous or not cancerous. And yes, quite frankly, better than radiologists in a standalone study. Significantly better, in fact. But this is not to replace a radiologist. Please understand that. This is to supplement a radiologist. It's to make them better. And by the way, this was trained on only inside of the prostate organ itself. So if that cancer has potentially metastasized outside the prostate, we do rely on that radiologist to look at the seminal vesicles, the bladder, the lymph system, etc. Therefore, again, the Prostate ID as a program plus a trained reader, the performance of the combination is far better than the individual parts. Just keep that in mind. So what we do is we take 3 of the input series from your MRIs, and in less than 5 minutes, once those are sent to us, it processes those and returns them back. So first off, you have to send your MRI image to PPC. PPC then sends it to Bot Image, and then it's overread with the PPC experts. So you've kind of been introduced now to the problems, the solution, and then the PPC and Bot Image. Now they're, again, different companies. Bot Image is a medical device company that does not service patients directly. PPC is the way to get this product out to the market to you specifically. It is for retail use where you can get it. You have control of your own health care. You can get this second opinion that is an expert already proven by the FDA studies and applications and such, that it's significantly improving the performance. So what you can do is you can rely on this being, if it tells you you don't have cancer, there's about a 97% chance you don't have cancer. That's peace of mind. So you can't imagine how many times we scan a patient that thinks they have cancer and the software says they do not. And on the same token, about 30% of the time, patients that have come back with a negative radiological report are shown that they actually do have cancer, and that's biopsy confirmed by a participating urologist. So that's the reason why you get a second opinion. Never, ever, ever get a treatment without a second opinion. And we're offering one that so far I have seen no statistics that are better. So why would you choose PPC? That's short for Precision Prostate Consulting. Big clumsy name, but that's the way it is in the web world. The old standard of care is finger in the rear, relying solely upon blood tests. Even the new tissue tests of today, even urine tests today, some of them have a very, very high sensitivity and specificity as compared to our 93.6%. However, even if you come back with a positive finding using a urine test, for example, you still have to know where the cancer is. And that's the other advantage of using this digital AI, because we're going to show you where the cancer is. This is an example of the report that one would get back from Precision Prostate Consulting. And by the way, the patient name up here, we're not violating any HIPAA. This is one of our employees. He has created himself as a false patient, signing in within a study that we had from long ago to test the program output. Now, this is a complex study. I'm not throwing this up to confuse anyone, but I'm throwing this up to show you we detect it all. There is a scattering of different lesions throughout this. You're looking at three-dimensional reconstructions of this man's prostate from three different views, actually axially, sagittally, and coronally. And the beautiful thing about this is giving a treating physician, typically a urologist or oncologist, a holistic view of the entire organ. They know exactly where the suspicious lesions are, and furthermore, they know what what we'll call the grade, if you will, or the classification of that cancer based upon this index value that they have in their user's manual. And so if it gets to a certain index value, it's called a PIRAD score, which you've heard before. The PIRADS scoring mechanism is a radiological tool. It's 1 to 5. 1 is nothing, 2 is maybe suspicious, 3 is equivocal, meaning 50-50. 4 means, yeah, most likely cancer. Well, we do better than that. We do a 100-point scale. I won't go into the calibration of that scale due to lack of time, and probably don't need to know, but we correlate that with the radiological PIRAD score. Now, one of the things that's really important about this is, again, we provide this view of the entire organ to give a lot better treatment planning and a lot better guidance for applying a biopsy needle or a focal laser treatment. And each one of these regions of interest are displayed for that treating physician. Now, I wanted to amplify these last ones here. Let's say that the patient only had a couple of these yellow spots, like right here. If that's all that a patient had, and we're looking at this and saying it's really only a PIRADS 2, you would be a perfect patient for active surveillance. Why? Because the software's been calibrated to say that the odds of this being a clinically significant cancer are 20% or less. So why not watch and wait before you go through the discomfort, the extra cost, everything else of having needles stuck in you to sample that particular point? There's another big advantage. And so for all of you on active surveillance, get a second opinion. You might have a cancer, and again, you may not have anything to even be worried about. That's the beautiful thing about the software. So on the back of this form, this is more for the radiologist. It's there for you too, because if you sign up, you get a copy of this report. And the physician that you sign up with you using their NPI number that you can get from them, they will get a copy of the report as well. It's for them to interpret. Understand this. We are consultative. We're consulting with your physician to help better guide them. We are not your doctor. We're not signed up to be your doctor. We're not licensed in all 50 states. We don't want to be. We're wanting to bring this to you so you have the power of decision making. You can take this to your doctor and you can say, here's some information from this AI. Go to their websites if you don't believe their credibility and check it out yourself and contact them. That's our recommendation to you. But this is a typical radiological sample report here that shows the different zones of the prostate and identifies those areas. So this helps even your general practitioner or your urologist that's really not used to some of the radiological terminology, so they can understand the report that we put on the previous pages. Okay, so we'll wrap up here real quickly about how to obtain the PPC service. Go to the website. There's very clear and specific instructions on that. One of the things that we've been challenged with is how to communicate with all of the men and their loved ones out there that have varying skills of computer savvy, right? So what we're talking about is if you can get help from your MRI facility, fantastic, because they can look us up. Precision Prostate, or PPC, is a Nuance Power Share Hub, which is a common Microsoft product on all these computers, in most facilities. They can easily transfer your images directly to PPC. If they're refusing to help you and such, maybe your personal physician can do the same thing. If they don't have PowerShare, have them help you log into this website and sign in. Again, if you don't have a computer, the last option is take that CD that you got from your MRI and express mail it to Bot Image. And when you get on the website, you will see that address. The big thing is you have to register yourself. Excuse me. Continue from here. You have to register yourself and that one. Now, yes, again, here's where the profit part comes in. We have to pay for our research and development and our service. So we do ask for a credit card payment. I'll tell you right now, it's not on there. It's $259, which is far cheaper than any blood or tissue test you've got out there other than PSA. We will not take payment until we see that MRI is proper and that it was able to send you results. Not all MRIs are going to be proper. If they didn't acquire those properly, and you'll get a notification of that. So after you upload it, the results will be sent back to you via email and to your physician. So the last question is insurance. The answer is most likely not. And here's why. And this is why we started PPC, because the insurance companies, my experience in 30 years of being in medical devices is they're 10 years behind the times. 10 years. So there's a few years left before they're going to start paying for AI routinely, although they've started. But if you have a healthcare account, personal savings account, the HSAs, whatever, then you can use the receipt from the PPC to get to use your personal healthcare account. So with that, I'll stop talking and enter into a Q&A session.
Bing, would you like to Would you like to
Yeah, sure.
in and give them the instructions and maybe
I will. And
Dr.
there's
Jones?
one question here from Bruce is,
I see
does it
that.
apply where the MRI is with and without
Yeah.
contrast? We prefer, Bruce, to have a non-contrast, or you'll see that many times listed as a BP MRI or biparametric MRI. There's a lot of obviously acronyms and abbreviations out there that you'll see DCE, which is a contrast element, or you'll see MP MRI, which is a multi-parametric MRI. So we prefer just the standard BP MRI, which is biparametric with no contrast. With no contrast.
Yeah. But I might add to that, Bing, is if your doctor or you sends the entire MP MRI with contrast, it's not a problem. We prefer it only because it's a smaller file. But the AI is already trained, it's smart enough, it grabs those 3 inputs that it needs, it throws the rest away. So it doesn't matter is the point. We'll take either one.
Great.
So
Ray, go ahead.
can I just say before people who don't know, there is a hands up function in the bottom on the right, on the left, I'm sorry, and use that hands up function. Commander Crosby is going to be monitoring who has their hands up. He's going to be going through that. So please use the hands up. Please use the hands up function if you want to say something. And Ray, you're up first.
Okay. 3 what I think are hopefully relatively quick questions. One is, does your software, will it compare 2 MRIs if you have 2 MRIs? And the second question is related, will it give a precision score or a diffusion score if you do have 2 MRIs?
Ready?
Excuse me. You
No,
want to
go
handle that,
ahead.
Bing, or
Go
I
ahead.
will? Okay. Yeah, the answer is actually we get that quite frequently, where you've got a history of MRIs, and it's really, we've used a couple of those actually as case studies, where a gentleman had an MRI 2 years ago, and they got X result, and last year their result was, well, they really didn't have a lesion where the report said they had a lesion, but there was, on the previous year, there was a small yellow spot, and now this year it's red. So that green, yellow, red is kind of the quick indicator, but the short answer is it's a beautiful tool for tracking the growth and development of a suspicious lesion. So absolutely. And here's the other thing that I didn't mention. Inter-reader variability, inter-site variability is huge in this particular medical business, meaning that you can ask 3 different sites to read the same MRI and you will get 3 different answers. That's the beautiful thing about this AI, is it is consistent and it's going to give you the same answer for that case regardless of where it comes from.
Mark Baldridge, your turn.
Yes. 5 years ago, I was diagnosed with prostate cancer. And like a lot of men, I had a bone scan that revealed no cancer. I had a CT pelvis with IV contrast, no cancer was found. And finally, I had an MRI, a pelvis with contrast. And the results of this were that there was no evidence of macroscopic extracapsular extension and also no evidence of seminal vesicle invasion. Well, 2 months after that, when I had a prostatectomy, both of those conditions were found. I did have the extracapsular extension with the seminal vesicle invasion. So basically, I feel like I had a prostatectomy, and I never should have. And so the MRI wasn't effective for me because I wouldn't have chosen a prostatectomy if I would have known. And I mean, this is 5 years ago, but like how can I use my case for a learning experience? Should I go back to where Virginia Mason, where I had this MRI? I mean, I don't want to have anything punitive, but I mean, I'd like this to be a learning experience so somebody else like me doesn't have a prostatectomy when they shouldn't.
That's really unfortunate. That's exactly what we're trying to prevent. So I appreciate you wanting to help mankind by sharing your data. And yes, we could use data like that. It's anecdotal, we call it, but as the case I just told you about, we collect some of these special cases to help demonstrate to the medical community that, you know, they're not always right, and they should turn to technology if it's available to help improve the outcome. So if you had those MRIs and the record associated with those, what we require are what's called ground truth, meaning they've removed your organ. Did they find cancer in your organ once they removed it? Did they do a histopathology analysis?
Yes, I mean they definitely found cancer in my prostate, and I was a Gleason 9, and that was confirmed after my prostate was removed.
Okay, but fortunately for you, it had not metastasized, correct?
As far as I know at that point, because I hadn't had a PSMA PET scan
Okay,
until even a couple years later than that.
okay. Well, if it was a Gleason 9, then it was certainly aggressive, and then you needed some type of a treatment. But again, we'll share this with everybody. It's a lot better to have options, and if you know this program detects cancer so early that a radiologist wouldn't even call it a PIRADS 2.
Mhm.
That's how sensitive it is. But once it gets to a Gleason 9, it is very aggressive. It needs to be treated. But again, the other value of the program is we get to see the extent of that lesion or those lesions in your body, as I showed you on that sample report. That if it involves a smaller percentage of your actual organ, then you have a lot of other treatment options other than radical prostatectomy. You can do a laser focal ablation or a cryoablation, or if it's in half the organ, you can do a half organ focal ultrasound. So there's just a number of different things that one can do besides cut, as I say.
Yeah. Thank you.
Okay. Thanks, Mark. John.
Hi, thanks for coming and talking to us. I'm glad you
How are you?
mentioned reliability. I was going to ask you if you did this exact same image 10 times in a row, would you get the exact same reading 10 times in a row? And I'm pretty sure you said yes.
That's correct.
And a thing that I'm always wonder about, one of the first things I like to look at if I look at a MRI reading is if the radiologist would make a comment about the image quality. And often they do, but often they don't even say whether they have a really good image quality or not. And this also gets to your point about detecting a cancer so early it can hardly be seen or register on the PIRAD scale. Can your reading, can your interpretation be trashed by poor image quality? Is there a certain amount of image quality impairment that will defeat your system?
Excellent question, John. The short answer is yes. We maintain a specific standard of image quality. In the user manual that we provide to our clients, hospitals and radiological facilities, MRI facilities, They have to follow the guidelines for acquiring that MRI. That's when I said earlier, if you have an MRI that was done poorly many years ago or even recently, because some of it's pretty bad, it'll reject it. But I can tell you this, that it's been trained on a huge number, over 1,000 cases with again, called retrospective studies, where they had biopsy data, three-dimensionally located biopsies. So we knew where the cancers were retrospectively, or that is after the effect, folks. So we could train it on that. And again, some of the image quality, John, I would call undiagnostic. I was a board certified MRI physicist. I taught this to radiology community. And many of my inventions were to generate a much higher quality image for radiologists to interpret. Because if it gets to be so bad that the noise is overwhelming, then I wouldn't want to sign my name to that report if I was the radiologist. If they're that bad, we've trained on bad, but we won't accept terrible. And
Yeah,
also
that's
there's
good.
artifacts, right? There's artifacts like if you've had a dual hip implant
Yeah,
and you get it on a high field 3T system, they're
yeah,
rendered useless. You
yeah.
can't use
Lots of metal in a 3T system. Does
yeah.
does the AI ever hallucinate? Is that why you have also a human radiologist looking at these?
Yeah, the answer is no. There's a difference between regenerative AI, which is, the chat GTPs and all that good stuff. This is a different class of artificial intelligence. And, most of the newsies that talk about AI, they don't know what they're talking about, and they classify them all in the same boat. This is not one of those that's going to be Arnie taking over the world, Arnie's enemy taking over the world. Arnold Schwarzenegger, of course, with the AI of the future. These things have been trained for a specific task, and they've been fed curated data, tons of curated data, so they can separate fact from fiction, if you will, cancers from many things that look like cancers and fool the human eye. And now that we're talking about it, I'm happy to say that this software is unique compared to any other are in the market, because we're using a technology that extracts 64 features from the 3 image sets that we receive, and a human eye can only see 12 to 14 features from those same images. So if it's been optimized to detect the cancer using all 64, it's going to outperform a human every single time within that data set of inside the MRI. It's like a human bringing a knife to a gunfight. It's that good.
Okay, next question, Kathy Baldridge.
If you could just clarify, with your product, does it would it pick up if somebody has that extracapillary extension, like my husband's case? Would that be picked up with your software? Because you mentioned that it would not pick up anything in the seminal vesicles, but it would it pick up anything in the extracapillary extension if that was present?
No, I understand your question. It's a good question.
Yeah.
What you saw in those images, and they were up there briefly, but it segments or colorizes the entire prostate with green. Green is good, meaning it's not prostate. And then it starts to turn yellow, meaning there's a warning signal that there's a potential prostate, and goes to red, which was a pretty indicative of a prostate. So if the red zone, thank you, Mike, for doing that. If the red zone is now touching the outer perimeter, it's called the capsule. if the red zone is making contact with that capsule, then it is now regarded as potentially extra capillary. There's the answer to your question. We're not looking outside of it, but we're being able to provide that radiologist the indication that says, hey, this is very likely has migrated. So that they should be putting that in their report, that this thing is now most likely migrated outside of the prostate. And they should then do the rest of the whole pelvis MRI, which they do, and they look at the seminal vesicles, the bladder, and the lymph system.
Right, because you can see how this is so critical for patients like my husband with a high Gleason score and
Right.
trying to decide whether to go radiation versus surgery. And he was told he had localized, cancer. And then, 6 weeks after his surgery, he had detectable PSA. So right off the bat, very soon he had to have salvage radiation and hormone treatment. So,
Oh my.
this
Yeah.
is all missed because of that one MRI, which somebody did not read correctly. I don't know what happened,
Exactly.
but yeah.
Well,
Yeah. So
I mean,
if they see this red impinging on the border, as we call it, the capsule, then really what should be ordered next is a PSMA test. That's what should come next. Well, after they do a whole pelvis MRI, and that's usually done in conjunction with the prostate, they should be looking at the lymph system, the seminal vesicles, and elsewhere. But if the symptoms persist, they should be going and getting a PSMA, because that is very indicative. It does show, metastasis throughout the rest of the body.
Yeah, unfortunately, in my husband's case, this was in the end of 2020. Well, the PSMA PET scan wasn't available. He had an Axeman scan, which did not show anything. So
no, those are
that was a problem,
okay.
5 years ago. But thank you
Right.
for that clarification. That for all the folks going ahead, that this is valuable because it would show this case, with
You
tell
bet.
whether there's the extra capillary extension. Thank
Tom,
you.
you're up next. Yeah, thanks, Kathy.
Yeah.
Tom? Tom, you're up.
Tom and Robin, still with us? We'll come back to you. You've also got a few questions in the chat.
Yeah, I
to
see those
relay.
going on. I see Milo's and Q's, and I will tell you that one about MRIs done abroad, I can answer that very quickly. We have submitted for and have been told it's imminent that we will have a CE mark. So anything in Europe is the same, essentially the same as the FDA approvals. And we're literally just waiting for the paperwork to show up. But all the inspections and audits have all been done, and all the approvals have been given. We're just now waiting.
And that's for bot image only, but for precision prostate, because we have these approvals here and we're making this consultation in the United States, you can use your MRIs from abroad right now to send it to PPC and get the second opinion.
Yeah.
Yes, it's good for both 3T and 1.5T and any of these PE Siemens or Philips scanners.
Okay. Who's next? I think Derek, are you there?
Yes, I am. My question is in regard to pricing. So I've had MRIs and guided biopsies 2 years in a row back to back. So I have two sets of MRIs. Would that be two separate 259s, or how would that work on the submission?
I'm sorry, I was getting a lot of feedback. Would you repeat the question?
Certainly. If I've submitted two different MRIs from 2 years back to back, how would that price out wise? Would that be 259 twice or one submission?
No, I appreciate the question. Right now, the program is rather automated, but if you contacted us on the website there and said you were going to do that, we would be happy to do both of them for one price of $259.
Excellent answer. Thank you.
You bet. I see a question about UCLA's Unfold AI. We do have a comparative analysis. I will say this, I'm not going to disparage any of our competitors. I will say this factual statement: the ProstatID is the uniquely FDA cleared on actually 6 different aspects, and no others have this clearance, no others in the world. Detection, diagnosis, screening using non-contrast MRI, lesion segmentation and lesion classification, as well as volumetric measurement of the organ so they can do PSA density. So it's uniquely cleared in all of those functions. And we also publish our sensitivity specificity results, and very few others do. Unfold, you will see, is not even on here because, to my knowledge, they've never made it a fully commercial product, but I could be wrong.
You're muted, Commander. Unmute.
Okay, I just want to let you know that here we're not afraid to put our competition up here. We're very proud of this, and while we hope everybody gets FDA approved, we're already there. The guys at UCLA, I was just there this last week, and talking to them, they don't have an FDA approval at the moment. Obviously, we're all trying. We think that we're ahead of everyone by probably a couple of years. But this is what's in the marketplace right now. This is what's being used. So we feel I'll be the competitive guy. I think we're winning the race right now. So but I can tell you the other guys are out there, but we're happy to have the conversation with any of them. Okay. Rick, you had a question, or your hand was up?
I do have a question. It's actually 2 questions, because the flip side of my question is actually in the chat window. Milo says, might this be useful to monitor men on active surveillance so as to avoid a biopsy? And I'd love for you to answer that one, because there's loads of guys who have that question. And then the question I had is, can you talk to how this could be useful for advanced men or men who have recurrent disease? So maybe you can take both sides of that coin and explain to us the relevance.
Absolutely. Well, first off, absolutely, this is the perfect tool to use it for fusion biopsy. We actually are auto compatible with a couple of instruments right now today. A Koala system made in France with headquarters also in New Jersey. And we've done recent tests on the MIM platform that goes to the GE fusion system as well. So the answer is yes, it provides 3-dimensional targeting for biopsies and focal treatment. So it's all automated. So those images that you're looking at are digitally compatible with those instruments, where it fuses the ultrasound in real time to provide the targeting. So great question.
But how about, Dr. Randy, how about avoiding? How would we use this so somebody didn't have to do a biopsy?
Exactly. So if you're on active surveillance, that's the point of this. It's a very calibrated, I'm going to use that expression, software. Again, been calibrated off of 6,000 biopsy points, anywhere from 40% of them were no cancer, and the other were different grades of cancer. So it distinguishes this level of classification, if you will. And so if I was a man today and I had, if I was on active surveillance, I would want to get this so I could get that report. And if it showed any suspicious regions, it would show up in a light yellow color, and it would give me and the physician a score. And that score, if it's a low enough number, if it's down there in the low 60s or even in the 50s, then then you don't biopsy it. The cutoff, I believe, if memory serves from our user's manual, if it's below 57.5 in terms of that index value, then it's less than 20% that's even a cancer. So then there's a nice decision tool there to have at your disposal. Go, well, you know what? I've been living with this for a year or two. It's still less than 20% cancer. I'll come and get another MRI in 6 months or a year based upon, other mitigating factors in your family history and such. So that's what I do. Right now, I'm on active surveillance. I get my blood test every 3 to 6 months. I see if I have accelerated PSA. If I do, I'm going to go get another MRI. And accelerated PSA means, is it doubling in 6 months? Yeah, go get another MRI. Let the AI take a look at it and say, well, okay, your yellow spot's growing to be a bigger yellow spot. The index value has increased enough. Now you may want to go get a biopsy. Those are the decision tools that this provides you.
Tom, to answer your question, I would say yes, as we talked about this as being a second opinion. I would encourage you to send it in and take a look at it, because if you've already got a biopsy, my question would be is what did they biopsy, or where did they biopsy in there? And you can confirm where that biopsy is. You can also now make decisions whether you want to do focal therapy, you want to do radiation therapy, or if they want to take it out, or whatever you want to do. But you can also see from these images here, we will tell you if it's extracapular. We can tell you if it's up against the capsule or if it's escaped the capsule, and you'll see that very, very readily on these on the images.
Yeah, and Bing brings up a really good point, and I was talking about some case studies that we had recently accumulated where there were back-to-back MRIs, and in year one, they said there was no cancer in this particular location, but they did say biopsy over in this other location B, we'll call it. Then the biopsy came back negative. They showed me the year two that they used then to be biopsying. And when we compared the location of their biopsy needle, because they tracked it on the Coella system, so it's a beautiful tool to show exactly where they put the needle. In the first year, they did not test the slight yellow one, which I wouldn't have either then because it was not even a PIRADS 2. In the second year, they missed the primary lesion of the first year, and we saw that just the weird shape, as you can see from this image that Bing's showing, these things are shaped very strangely. And understand, in a black and white image, all the radiologist sees is maybe some irregular looking image, and they have no idea where the center of this target could possibly be. So this particular patient had a large abnormal looking MRI, and it showed exactly where they put the needle, which was in the center of this relatively circular lesion. They completely missed the red spot, and almost the yellow spot was dwindled to nothing. So the needle that they put, thinking they put in the center of the lesion, they completely missed it. And in the lesion that the patient had the year before at location A had grown to be a significant cancer in that following year. So in that one patient, we had two different findings that could have been prevented had they had this AI interpretation.
So Randy, this is Rick. I want to focus you back on the second half of my question, especially since someone else has asked it in the chat, which is, how do we use this for the advanced guys who are on the phone who might be considering biochemical recurrence, or guys who, for example, have been on intermittent hormone therapy and now they see their They see their PSA rising 3 or 4 years out, and they want to know where it's coming from. How can we use this technology for those guys?
Good question. Depending upon whether they have a radical prostatectomy or they're still under some type of hormone or other therapies, the answer varies a little. We currently do not have the FDA clearance to ascertain that this is accurately detecting a recurrence after a radical prostatectomy. We've collected close to 100 cases that we are training on right now to be able to add that to our FDA clearances. But we can't say definitively that it will be useful for that. I can just tell you that working with this particular university, the results look pretty good. So if you wanted to use this as a test case, then, and we would so identify that and document that, we would willingly have you participate in this study.
Okay.
If you're on other types of therapies, what we ask is that you, if it's like a radiation therapy, you wait at least 120 days before you get your MRI post-treatment, meaning we don't have enough data, the whole medical community does not have enough data to show what type of intracellular changes have taken place in the tissues that would affect the outcome of this AI. So we also have to use a caution there and ask that you wait at least 120 days before you do that MRI. But then, yes, I would do it then.
And what about radiation? If you were treated originally with radiation, do you have any data for that?
Same thing, 120 days. Wait.
Okay. Okay.
Rick, I can tell you that so I've had radiation a number of times, everybody knows, and they say my prostate looks like a piece of used chicken in a microwave, but it's still there, and we're going to do mine in here and see what it looks like, see what comes out of it, but we'll see. So the answer is, yeah, we're still looking. If people want to try it, we'll probably find a reason to try it. Stuart,
before we got a couple of questions still in to answer here and some in the chat, but please can you tell people a little bit about how they can access you? Somebody's asking about which institutions already use your technology and it's already integrated.
Yep.
Can you address that a little bit, please?
Sure.
Well, Randy, go ahead. I mean, we've got about 20 plus institutions so far, but we can get you a list, or you can send us where you're at, and we can try to refer you to the closest guys. Or it's probably the best way. Or we can try to refer you to maybe to one of the radiologists that we work with already. And I'll put my email in the chat as well.
Right. Well, one of the challenges is you're asking about doing a targeted biopsy. That's even a smaller number of institutions that have that because of the compatibility that we're talking about. We're working quickly to add this to other instruments, but if they don't have a Coelis or a MIMS system, we're not automatically compatible, and radiologists are reluctant to utilize that, unfortunately. Again, that's the battle that we fight continuously. But again, as being said, we can at least refer you to places that are utilizing this, and we're adding to that list on a daily basis. As far as what was the invisible tumor question from Paul? That's a great question. I get this from radiologists frequently, and my response is invisible to whom? It is invisible to the human eye. We are doing experiments and wanting to have some co-publishers in academic institutions. I pose it that because of the 64 features that we utilize to train this software and actually use it for detection, I do not believe that there are many cancers at all that are invisible to this AI. That is my supposition today. We hope to have some academic papers out proving just that. And this is a perfect slide. Thank you, Bing. We're doing these experiments in R&D daily to actually be able to differentiate the severity of cancer that we actually do detect. It's coarsely graded right now, and we're working on fine-tuning that on a daily basis.
Randy, will you allow us to share these slides afterwards? Can we attach them to the presentation?
Certainly.
Okay, well,
Yeah,
so
we can do that. Yeah.
And we'll be posting this on our YouTube channel and also on our blog, and we'll be sure to attach the slides. Bing, you've got a question from one of our board members, Stuart, and then I have a special guest to introduce. So
Okay.
after Stuart, allow me to introduce our special guest, and then we can go to Dr. Alfredo, and that should take us up to time.
Okay, go ahead.
Hi, I just wanted to follow up on Rick's question, again, from the perspective of someone who has been treated and is being monitored post-treatment. Is the AI going to be trained on specifically post-treatment situations as for either radiation or focal?
Yes, it is. It's all a matter of collecting sufficient quantities of data. So that's we work with our partnerships at certain university hospitals, and that list is growing as well. Bing has made great introductions into the VA, for instance. So we trade a lot of services for data. And it takes a tremendous amount of data. We have to have hundreds of cases to be able to make an impact on the training of the software. But hang on, we're getting there.
Great,
I
thank you.
want to expand on the data issue real quick, and because that's what sets us apart from a lot of those competitors that are out there. Our data is not bought data. It's not like purchase data. Sorry. This is data that has been tracked from guys from initial diagnosis all the way through pathology assurance of the tissue that's being analyzed by the MRI and compared, and then analyzed by our AI. So the system knows what it's looking at because it's all been verified by pathologists all the way down to the slide level. So that's why we are very proud of our database, and we know that the value of it is extremely good, and the results are starting to show that right now.
So about 2 or 3 months ago, Bing came to me and he said, do you have a couple of guys that you could find, because we want to test a couple of things about uploading and downloading from the website and this, that, and the other. And I said, I'm sure we can find a couple of guys for you. And we had one of our active surveillance moderators who has a very unusual case of prostate cancer, in that he's got 11 out of 12 positive 3+3 cores, which is not a great situation, but it's 3+3, and people like Dr. Klotz and Peter Carroll said you're safe to keep going. Well, he got into this webinar a little late. Eric, I'd love for you to tell the audience and the webinar how using Prostate ID helped you.
Yes, thank you, Rick. Yeah, I had a random blind biopsy initially from my urologist, and it came back with 11 out of 12 cores with Gleason 3+3, confirmed with Dr. Zhao as a second opinion. And then being Mr. Crosby was able to work with me and get my slides uploaded. So I have like about 3 years worth of MRIs or 3 sessions.
Yeah.
And you can definitely see the progression, and it's really fascinating to see the detail and the quality of the 3D map of this, in my case, my lesions in the report. And I can't wait to use that report for my next biopsy so they can target it precisely and get an actual non-blind and a fusion-guided biopsy next. So big thank you to you guys for that.
Yeah, Eric, no problem. And, just so everybody knows, it takes minutes to figure this stuff out. It's not like we have to wait for a long time. We ran his through kind of a clunky system, just so we could get the data to us and get it done. But yeah, we're happy to help. I mean, it's that's why we're here. And I mean, it's let us know, and if there's anything else that needs to be done, or if you guys need to consult with us, Eric, you know that.
Thank you. It was amazing.
Yeah. So Alfredo, you had a question, and then I think we need to move on. I think Rick.
No, we can keep going until about 5 of.
Okay.
So we've got
there was
another
a question about contrast. I want to answer that one as well. About the potential risk of gadolinium. We don't.
Go ahead and do the gadolinium answer.
Sure.
Okay.
And yeah, there's a percentage of people that have a reaction, a pretty negative reactions, anywhere from minor to severe. And if you have a compromised kidney, you're not indicated to use it at all. The point is, our software is proven in our clinical studies to be as good or better than the full contrast MRI study. So, we're making the claim boldly that you don't need contrast, period. I found that radiologists have a certain dependence upon that because it helps them make the decision, their diagnostic decision. And what we like to tell them is, why don't you substitute AI for contrast and help you make your diagnostic decision that way?
Yeah. Alfredo, go ahead.
That's a good way to put it. So I'm just going to shift the focus a little bit. In a way, you guys have probably answered this question indirectly. I want to switch to epidemiology. Are you thinking that in a few years, probably not that many, every man who goes in for his so-called annual physical, which I'm supposed to do in a couple of weeks, will get an MRI and this AI technology? And at that point, it's screening, right? We'd say and I don't know the age cutoff, but it might be a young age, because by then MRIs will be cheap and your software will be cheap, and so we'll just do it for everybody.
We're actually in discussions to partner with another company it's another subject, but they're doing a new blood test that will actually compete against PSA, and that'll come out hopefully fairly soon. But we believe that blood test will definitively tell you that if you have cancer in your whole blood or not. And if you do, then you should have an MRI, because we are approved by FDA to screen for prostate cancer inside the prostate. Okay?
And to Dan, go ahead, Mike.
Yeah, and so we're the segmentation and the other big words after that all come with it, but we are cleared to do screening from the FDA. So yes, I think so, Alfredo. I think that's the way to do it, and also to mention that when you don't have contrast, that MRI only takes you 20 minutes, 15 to 20 minutes. It's not that laying in there for an hour to 45 minutes to an hour. So if you think about throughput and the amount of time, we also have approved CPT codes. So if your urologist can now order an MRI and he can actually get reimbursed for ordering the MRI, we think that's an incentive.
AI, yeah.
With AI, yeah, right. He can get reimbursement for using the AI. It's a good incentive for them to start using it in their diagnostics type of situations, and I think that's the scaling and the marketing and the push that we're trying to do, is to educate the industry that we need to do better screening. We need to do it earlier, and we have new technology that applies to that screening challenge.
Thank you.
Yes, sir.
I see a question from Jim Marshall. Yes, with Precision Prostate Consulting, we do maintain the images on file by a patient register number only. We keep no HIPAA or FI, patient confidential information, but we keep that number. So if your physician wants to have a consult, then we have to refer to that number. But yes, we will collect data that way and be fully HIPAA compliant, and we can utilize that down the road, as you say, as long as we are also made privy to the biopsy results, if some are made. And that's the big challenge, is the MRI in itself does us no good. That's why we have to typically have research partnerships where we get also the record of biopsies and their pathology reports. That's what we call the ground truth that is used to validate the accuracy of the program, as well as train it for other uses like post-treatment MRIs.
That's great.
Did we get it? I think Jeff Markey had a question in the chat. When they do an MRI with contrast, they do a regular MRI first. Is that first MRI sufficient?
Yes.
Well, the answer is yes, and they typically do that all at the same setting. You're in the bore for 45 minutes to an hour if you have contrast added on, but they do the entire regular, as you call it, the BP MRI first, then they add on the contrast study at the end. So they already have all the data we need before they start contrast.
Okay. How are we doing? Anybody have any more questions or issues? Or if not, we'll give you some more information and we'll start to wrap up. It doesn't look like we have any more hands up, so let me just say a couple of things. First of all, a huge thank you to Dr. Randy and to Mike Crosby. I meant to and forgot, but I will do it in a second. I want to put in the link for our webinar coming up with Dr. EPSTEIN, because what we're hoping is that Dr. EPSTEIN and Dr. Jones will have a little conversation pretty soon about AI. That's what we're looking to have happen. Secondly, there is a link to Precision Prostate at the bottom of the chat there. There's also a link to sign up for any of our groups. And I want to invite anybody who's here to stay on the line. Just don't leave the room. We'll be segueing right into a active surveillance support group session. Gary and Hugh are both present now, and they'll be taking charge of that session. It will not be recorded, although we do record these sessions on 2nd and 4th, but this is a third Monday. This is a third Wednesday, so it won't. Let's see. Anything else other than a huge thank you? That's it, and I'm going to hand it to Bing and to Randy to wrap up, and I'm going to go look for that sign up for the EPSTEIN, which is going to be on the 30th, and it will be free and drop in just like this, and we'll be posting this as soon as we can with the slides. Okay, go over to you, Bing, to close out, but don't shut us down because
no, I'm not shutting anybody down. You guys, I appreciate the opportunity to chat. Obviously, being an advisor here today, AnCan, I'm proud to participate in any of these things. You've got my email. If anybody has a request, Randy and I will get back to you. We're scattering around. We have had some discussions with the ASPI team while we were at the Prostate Cancer Research Institute Day, and again, just thanks for your interest and your participation in this evening's talk. And just thank you again, Randy.
Thank you, everybody. I appreciate the audience today and your questions. It's an honor. Appreciate it.
Hey, Randy, it's Eric. A big thank you as well.
You bet. All right. Good
Thank
night,
you, everyone.
everybody.
Okay, hold on, don't go away. If you're looking for the registration, I'm trying to find it quickly to put it on here. Unless Archana has it and she can beat me to it. So I'm gonna have to take it off a flyer.
I'm also checking.
Yes, it's on the printable flyer, so we'll take it off the printable flyer. And
Isn't it the
anybody
same
else?
room?
Oh, yeah.
Yes, we're staying in the same room. Don't go anywhere. Your meeting's going to start in this room momentarily. So,
I'm going to snip it.
Okay, you got it. Good, great, well done.
Yeah.
Snip it and put it in. Although I wonder if that will be.
Let me just see.
Tell me if you got it yet.
Yeah, I snipped it. Let me just make sure I'm able to get it on here.
Okay, sorry guys, we should have done this. I didn't think about it until the last moment.
Neither did I. Yeah, neither did I. Yeah.
And we should have been pushing that webinar long ago. So I think I have it. Yes, I have it, and I'm going to post it as a clickable link. I've got it now as a clickable link. I just have to come back to the room. Here I am. Here you go. Thanks for hanging in. It's there. You can click that and you can register for Dr. EPSTEIN. For those of you who don't know, he's probably the foremost genitourinary pathologist in the world. I mean, I don't think that's an overstatement. So there you go. And everybody and anybody can please stay on, experience an AnCan group. It's going to be a bit of a handful for you and Gary, but I will be here to help you, and we'll get through. We'll manage to find a way to get through everybody. So, all right, I'm turning off the recording.
This conference will now be recorded.